Good morning, everyone. I'd like to welcome you to today's conference on the Sentinel Initiative. Our Sentinel Initiative Public Workshop is now in its 9th edition. I'm Mark McClellan. I'm the director of the Duke Margolis Center for Health Policy. This is a public workshop supported by a cooperative agreement with the FDA, and we're very pleased that so many of you are here with us today in person, and many more are joining us on the webcast. As I said, this is the 9th year of the Sentinel Workshop. It's provided an important venue for communicating about FDA's progress in developing the Sentinel system, about some of the activities of the Sentinel system, and about ways in which many of you in this room and others can work with and use the results of the Sentinel initiative, which, as we'll talk about today, is having more and more applications. In past workshops, we focused on a range of topics demonstrating the surveillance capabilities and the opportunities to develop useful evidence on public health issues from real-world data, now comprising a very large part of the American population. And last year was a particularly notable event as the mini Sentinel program transitioned out of its pilot phase and into an established and increasingly integrated FDA program. As Dr. Janet Woodcock said at last year's public workshop, Sentinel has become an integral part of routine safety surveillance at the FDA. Over the last 9 years, we've seen the Sentinel initiative truly change from a concept to a pilot set of activities to now an integrated reality in American safety surveillance. No longer are we just discussing possibilities, but rather we're focusing on an increasing array of milestones and an increasing potential for developing better evidence to influence and impact important issues in public health related to medical products. Sentinel is now utilizing more than 300 million person-years of quality, curated, unduplicated data to conduct rapid, active surveillance. The workshop today will highlight how FDA is taking further steps to integrate the Sentinel system into regulatory decision-making. We're going to get a chance to hear about a wide range of analyses that have been and are being performed by FDA, as well as work being done by FDA and collaborators. This is, again, a public-private effort to leverage Sentinel as a core component of our nation's learning health system to improve the quality and value of healthcare. So we're going to start with remarks from Dr. Rich Moscicki, who's the Deputy Center Director for Science Operation at FDA's Center for Drug Evaluation and Research. He's going to share his perspective on the Sentinel Initiative's progress and the agency's vision for the future, and Rich has been closely involved in this effort for quite some time. We'll also hear from Sentinel leadership within the different centers that are contributing to these new steps in developing better evidence from actual use of medical products at CDER, at CBER, the Biologics Center, and at CDRH, the Device and Radiologic Health Center. We'll hear about what their respective center priorities are for issues related to Sentinel and public health surveillance for next year. We're then going to move into a session that will focus on the day-to-day operations of the Sentinel Initiative with a presentation from the principal investigator of the coordinating center, Richard Platt. The second Rich is also a key figure and has been from the beginning, from that conceptual phase a decade ago, a key figure in Sentinel's advancement, and it's always great to hear from Rich. After Rich, representatives from CDER's Office of Surveillance and Epidemiology and Office of New Drugs, and from CBER's Division of Epidemiology and Office of Biostatistics and Epidemiology will describe how Sentinel tools and query results are being integrated into the agency's programs and workflows. And they're going to do that through some concrete examples. We're then going to take a short break, about 15 minutes, right before 11 o'clock, then back into session at 11 a.m. We'll go into presentations from staff at CBER, the Biologics Evaluation and Research Center, highlighting some significant evaluations that have been completed recently. We'll take an hour break for lunch at noon, We're then going to reconvene at 1 o'clock to hear from the staff at the Center for Drug Evaluation and Research about some of the high priority evaluations that they have completed and how they are informing and building on this work more broadly. At 2 o'clock, we're going to shift to the update from the Sentinel Coordinating Center work to improve stakeholder awareness and understanding of stakeholder goals and capabilities. And I want to encourage you to come to that session. I think some of the important further steps with Sentinel are going to involve increasing interactions with stakeholders and consumers and increasing activity there. We'll have another short break at 2:45 to 3, and then our final session of the workshop is going to focus on efforts to expand the uses of the Sentinel infrastructure to address other high priority health questions. This is a distributed data infrastructure that keeps core data for individuals at home and that has potentially a wider range of applications, considerably wider than the very important applications so far in safety surveillance. Now, before turning to Rich Moscicki for his opening comments, I want to go over a few housekeeping items. This is a public meeting. Besides the in-person attendees, as I mentioned, we're very pleased to have people with us on the webcast online. The record of the webcast will be available on the Duke Margolis website after the event as well. I also want to emphasize that this is not only an opportunity for people to hear about what's going on from the FDA and the many other stakeholders involved with the Sentinel program, but also an opportunity for questions and comments from all of you. We've set aside some time in each session to address public comments. We're going to try to do that throughout the day, and we hope to hear from people online as well. As a heads up to the speakers and panelists, Isha Sharma, Isha, you want to wave, is going to be the enforcer to keep us on schedule with signs to indicate how much time we have left in each of the segments within the presentations. And for all of you, please feel free to help yourself to coffee and beverages throughout the day. They're located in the further back in the room. And I'll say more about this as we head into lunch, but lunch is on your own, that 12 to 1 hour. There are many restaurants and other eateries close by. We're going to provide a list of nearby restaurants. I think you have one in the reminder email that we sent out about this event yesterday. And if you have any questions, please check with our staff at the registration desk. There are lots of options for lunch around here. And you're welcome to bring food back to the room. So let's get started. I'm very pleased to hand things over to Rich Moscicki. Rich, again, is the Deputy Center Director at CEDAR at FDA. Rich, thank you.
Thanks, Mark. Well, it's a great pleasure and good morning to all of you. I know many of you have traveled the distance, and we're very pleased that you're able to be with us here today. So I'm going to begin by really congratulating the entire Sentinel team. I mean, it's only been 1 year since we actually put together and said we're standing up Sentinel. Not many Sentinel, but Sentinel. And in that year, I think there's been amazing progress to keep us moving forward. I want to reiterate, too, how important Sentinel is to FDA across the board. It remains a very strong priority across our medical product centers, and I think this progress that we see continues to tell us that, in fact, our investment and our reliance is being paid back in a very important way. Drug safety today is better than it has been in the past, and it points us to how drug safety can be even better into the future. So there are several elements that I want to particularly bring out in my comments this morning. The first is that over this past year, we've truly integrated Sentinel into the regulatory process. Both CEDAR and CBER Sentinel programs have truly made this part of their post-marketing surveillance and risk assessment programs. They've done this with standardization of the signal assessment processes, comprehensive training and outreach to the scientific and regulatory staff, and now the adoption of this across a broad range of our medical product areas. During this time, we've stood up a governance system that is agency-wide involving CDER, CBER, and CDRH. CBER is here. Stephen is going to tell you a little bit later about how they've expanded their vaccine and blood product surveillance capabilities under their PRISM, that is the Post-Market Rapid Immunization Safety Monitoring Program, and BloodScan, their blood surveillance continuous active network. And we're going to also hear from Greg Pappas about coordinating the Sentinel activities with CDRH to leverage our infrastructure and complement what they put up as the National Evaluation System for Health Technology, or NEST, which allows now us to begin to look at this type of approach as well for medical device evaluation and regulatory decision making. So what that integration has now done is said that we now are in a phase of routine use for regulatory decisions. We've stood up ARIA, which you're going to hear much more about, which is the Active Risk Identification and Analysis System, which I think is going to be extremely important in how this works going forward. We've also held periodic trainings to increase our Sentinel expertise among our staff, and this has led to a significant increase in the automated tools and data over the past year. To give you a little color on that, in 2016, between CBER and CDER, the use of Sentinel involved 18 active protocol-based assessment, 74 ARIA and rapid query assessments, over 70 medical products, and 1,100 scenarios that were evaluated. Now, we're going to go into a little more detail with some of those. Rich Platt, and does anybody name their kid Richard anymore? I don't think so. And yet here we have an embarrassment of riches. And some of my FDA colleagues will highlight some of these assessments during our public meeting. The other aspect is we've continued to have growth. There's been growth in methods, data type, and source, and I'll even say access, and we'll get to that a little later. So we've continued to develop analytic methods. This allows us to ensure that we have a robust selection of analytic methods to address the variety of safety questions that we're going to face. Why does that always happen when you're speaking? It's my birthday, so I'm sure it's someone who's wishing me happy birthday. Thank you. I should have shut it off. It'll go off in a minute, honest. So in this growth, I want to say that we've now can access the electronic healthcare data of over 223 million members, including over 425 million person years of observation time. 43 million people are currently accruing new data, and 5.9 billion dispensing are available to us. Our data also includes now 7.2 billion unique encounters and 42 million people who have at least one laboratory result for us to be able to query. And we're continuing to expand access to new quality-checked healthcare data types and sources. And I think you're going to hear a lot more about that from Gerald in our next session, so I won't go into, I don't want to steal all of his thunder. And we have 4 other data expansion projects that are underway at the present time. Now, this meeting today also emphasizes another important aspect, and that's the engagement of all of you and our stakeholders and public. The importance of our communication regarding our activities and capabilities was in part mandated by PDUFA 5, but it is something we're very happy to do. And our report and assessment on this is, will be posted by the end of this fiscal year. That will allow us to really try to explain where we've gone with the strengths, limitations, and uses of Sentinel. We've also successfully completed PDUFA 6 negotiations, which have included aspects of Sentinel, and that emphasizes the enhancement of our communications with our sponsors and public. And we've revamped the Sentinel website to increase accessibility and usefulness to the public and other stakeholders. And this afternoon, you're going to also hear from our colleague, Steve Makita, who leads the Sentinel Engagement Partners Work Group. And I think he will go into much greater detail around these issues. And finally, I want to come to access and the growth of access. We have always envisioned that Sentinel should be a national resource, ultimately. And even more so, we believe it should be part of a much larger national resource that allows us to look at real-world evidence in a variety of ways, certainly with drug safety in mind, but beyond drug safety for other uses. So we remain committed to supporting this. We remain committed to create a national data infrastructure that would enable external stakeholders, other agencies, researchers for academia or industry to also be able to access the Sentinel infrastructure for a variety of purposes, medical product research and quality improvement as examples. So in fact, I can say that this year, access to Sentinel or a Sentinel mirror image has now been extended beyond FDA through the Reagan-Udall Foundation's Innovation in Medicine Evidence and Development Surveillance System. That's a long amount of words, but we'll call it IMEDS for short. And in particular, IMEDS has established a framework using input from a broad number of stakeholders that allows private sector entities to gain access to the system under a situation where there is an appropriate degree of oversight. And this framework, in fact, was already tested by Pfizer and the data partners and the operations center to examine 2 different safety issues. So as a result, the FDA Sentinel system's distributed data as well as scientific methods and tools are now available for entities outside of FDA who want to conduct important research to advance patient safety. Another interesting aspect of this is how we will also work with patients. And FDA has launched FDA Catalyst, a strategic effort that leverages the Sentinel infrastructure by utilizing the data available through its data partners and supplementing it with data from interventions or interactions with patients or providers. And the FDA Catalyst has already got 2 projects going, and you're going to hear more about that later, so I won't go into a lot of detail on that at this point in time. I'll just finish by saying we need to focus on this sort of capability, not only for observational studies, but also for randomized trial in a real-world setting. Sentinel is a demonstration that this can happen. We know that there are many other projects, PCORInet, the NIH Collaboratory, CDRH's NESMD, and IMEDS that all share these kind of goals and objectives. And I think it points to the importance of collaboration and cooperation. So we must focus on this to realize this potential. And not only will such collaboration directly serve the public health, but it will also sustain these programs as we make sure that stakeholders, such as those of you present here today, have an incentive to continue to provide support in general for its maintenance and its continued growth. Thank you.